Record.
Okay.
So I was going to bring up the case study. I don't know where I put that.
So I've got
I have it up to.
I have it. You want me to read it?
You guys want me to just like screen share it so we can all see it right there?
I've got mine.
Okay, perfect.
Now, who's writing? So we
The
each
notes.
write a paper, or we write one paper?
We write one paper.
Right.
Okay, I'll do this week if you put it to somebody.
Okay. Sure.
I'll do it.
What did you say? You do it. Okay.
Oh, are you doing it? I didn't know.
I mean, I can do it and send it out to everybody, and you all can put y'all touch to it.
It's up to you.
I was thinking we probably will just want to rotate anyways, right? So
Right.
So yeah, since Jennifer, you wrote the points last week. Maybe who wants to go this week? Don't put me out there yet.
Yeah, it doesn't matter. I didn't know, D'Anthony, that you wanted to. I was just off.
Not really, but we gotta share the wealth. I don't really want to.
I can write it this week. It doesn't bother me.
Okay.
Okay, I don't make against that.
And we all can just look at it. Okay.
Yeah, and I'll just send it out before I submit it for sure.
Okay.
Okay.
all right, let's go with that.
Okay.
So what do you guys think about one then? Why do you think Gary is so reticent about counseling? How could you discuss this with him if you were the therapist? What do you guys think?
Okay, can I go first?
Yeah.
When I was reading this, something came to mind. I actually had a client when I was in my practicum and some part of my internship that was kind of similar to this person. And what I told her was I had to explain, because in our own case, one thing with African American, being African American is like what I read, they are not really so comfortable with counseling because they don't trust therapy. So I had to like first gain her trust. And I tried to explain, being that she was on medication, that she needed to have both go back to back. That is like having psychotherapy and having that, because as a therapist, I have to like get feedback or know how the medication is working with her. So I know how to relate that to her prescriber, which was a nurse practitioner. So yeah, I was able to like get her to come up. I was like, because what they did at the agency, if you want medication or you want to continue getting medication, you have to come for therapy. So we had to always explain why they need both together, so, and that was able to keep her coming in for counseling. So yeah, I think the same thing would go for Gary, try and gain his trust, try and understand why he's kind of reluctant, and help him understand that he needs to have both go together, psychotherapy and drug therapy, if that makes sense.
Mm-hmm.
Yeah.
I agree with you. And I think the first thing we have to think about is his culture. With African American culture, even in the book, it talks about the mistrust regarding oppression with being given more. They talked about giving older medication and talked about how they treated them. And in the African American culture, they think that anyway. So
right.
I think a lot of it is not trusting counselors and definitely not believing in counselor, and also mistrust of medication. Will they be giving them the right medication as well? So.
Right.
The one thing that came to my mind immediately was where it said he was a high achiever.
Yeah.
And drives himself hard. Like for me, because I have anxiety, my first thought was I have like a retainer thing in my mouth. Was that he probably feels like he should be able to do it on his own and handle it on his own. Like, why is he not able to control it and be in control?
That's another point. Yeah.
Especially because with his grandma, or was that his grandma? His mother.
Yeah.
Him being in situations where he's not in control of what's going on with the cancer, with the car accident, and just that, I don't know. And we want to know what he felt wasn't for him having therapy before.
Yeah.
Right.
That's another point too. Yeah. Go ahead, D'Anthony.
I mean, I think that's key too, because it said it wasn't for me. So with that, we definitely have to lead in and ask, why wasn't it for you? I mean,
Mm-hmm.
what was going on that you said that it's not for you? You know, so how could counseling help? And I mean, he's reluctant. I mean, I do know in the African American culture, African American men do not go to counseling. I mean, it's like pulling teeth for them to go to counseling, even if they have a bunch of issues. And it just coincides with what's in our book, and even in our multicultural book that we had as well. So I looked in that too, and it did the same thing. It's the trust issue, even though he went there one time.
I remember reading that.
Yeah. Mm-hmm. He went there, but you know, it probably just confirmed what he thought. Well, I can't do this. I'm not doing this.
So I was actually, if I could jump in, I was thinking that just providing some psychoeducation and also providing him the space to ask questions and maybe even get an idea of the different modalities that could be used to treat those specific symptoms, so that he just has a better idea of what to expect, what he could choose, and then maybe even use motivational interviewing to help him see if that's something he wants, you know, because we are not in the position of forcing him to do counseling, you know, and that's right. And it's not going to be successful if we do. So just really providing him that platform of, let me educate you on what it would look like. But let me also give you a place to ask the questions, and for us to have that dialogue of different cultures and what he expects from counseling, so that it would be a more open platform for him. And I think especially coming in as, you know, it said he was an engineer at a local firm. He's an educated guy. So I think being able to give him that head knowledge as well, and even maybe normalize, like, these symptoms that you're experiencing is normal for what you have experienced. And these are the, you know, research modalities that could help. And then just offering him that for him to make that decision. True.
Yeah, what might help with trust is if you kind of, like, you created a plan, that he would maybe know what more to expect.
Exactly.
In the next session that's coming up and stuff like that.
Exactly.
And another thing I was thinking is, like, the stigma that comes along from, like, his age group and older, that we were reading. I read it was like chapter 4 of this book, just talking about there's a stigma, you know, about it, and you must be crazy and stuff like that, if you need a pill or something. And I'd want to know why he had therapy before, because I feel like it would answer a lot of the other questions.
But it said the same thing, that he had it after the accident. So our first answer to the first question, why do you think he is reticent about counseling, will be mistrust.
Yeah.
Because our head is the paper heading have to line up with the question.
Yep.
Yeah, I have a bunch of things that we talked about. I was going to look at a few things that we.
Yeah,
I just have to organize it in my head.
Oh.
I was just going to say, everything that we talked about all ties into trust and mistrust. Because we are kind of saying the same thing, but differently. Like what Jennifer was saying about he's a high achiever. That's kind of part of it too. Then Alyssa came in with having to, because he's an intelligent person, you have to come to him that way, you know, psychoeducation. So we're kind of all saying the same. It all boils down to him gaining a therapist's trust. And, you know, yeah, so yeah.
Okay.
Yeah. Anything else on that one? Or you guys want to move to the second question?
So we've also answered a question about how we would discuss it with him, right?
Yeah, I think that was.
Okay. So now we're
going.
So then it went into us getting to use this little book that I hadn't opened yet. That's
right.
So what do you guys think about the second question of what would you tell Gary about the side effects?
So for me, like, I know we're not really supposed, I'm so sorry. We're not supposed to really talk about medication per se. We can help educate, I would really kind of maybe go over that book with him or something similar. But tell him if he has any specific questions, you need to ask his provider, or ask if he had already asked and see what his concerns were about what she said.
Mm-hmm.
Okay. To add to what Jennifer just said, the agency where I was at, they just tell you you kind of have to learn about the medication at least, so that when they come in and tell you, okay, this is what they are feeling, you can know that it's a side effect of that medication. But to go in details, they have to go to the APN who prescribed the medication. So that's what I do in this case. I just Googled. I forgot that we had this book.
Right. But my concern is like, so if he was taking, say, like Lexapro, a common side effect for that is a headache. But if he were to come and say, oh, I have a headache, is this normal? And I say yes, as not being a healthcare provider, it could be a brain tumor. And I'm like, oh, it's fine. So I would be like, any kind of symptoms you need to talk to your provider about, we can kind of go over stuff together, but I can't give you any kind of
guarantee and say this
medical
is
information.
And then
so are you saying that we can't tell them the side effects that we know? We can't tell them their symptoms, but I mean, the question is, what we tell Gary about the side effects, about the medication? So are we saying that we can't tell him? He's not telling us what his symptoms are. He's just asking what the side effects are regarding that particular medication.
Right. And what I would do, and what I've been taught to do at my site, because I work with psychiatrists, you can get into deep doo-doo for talking about medication as a counselor, because you can't prescribe it. So all I would really do is kind of read through information with him to kind of explain that or explain why. But I would never say, oh, you can expect this, or it might make you this.
No. I mean, you can't use this book and show it to them and say,
yeah. That you could for sure. Yeah.
Okay, that's what I'm just.
Oh, okay.
Yeah. No. Okay, because that's what I was saying is explain the side effects that's listed in the book for that medication.
Yeah.
Which he should have.
Hey, this book says, let's look at it together. Yeah. That's right.
Or explain, or he could refer him to don't all the pharmacists actually give you a sheet of side effects?
Yeah.
And another thing is just going based off what I've done before. Like when they meet with the APN, the APN already have their notes. Just like you will have your notes as a therapist. They write what they discuss with them and the side effect of what to expect of the medication they discuss with them. So if the client, in this case, let's say I'm seeing Gary and he comes to me, I'm going to go based off of the notes that the APN already wrote down and be like, oh, I see here that you saw the APN as scheduled and you or she already discussed the side effect with you. And if he says, oh, he's already experiencing that, or if it's kind of something very severe, then I'm going to have to help them schedule another appointment to meet with the APN again. But and like Jennifer was saying, I can't just go and I don't have the qualification, I can't tell them so much. But yes, we are supposed to have this basic knowledge about the side effect of the medication.
Rachel?
I think I'm freezing.
Rachel? You're frozen.
Yeah, can you hear me?
There you go.
I know. Yeah. Am I back?
No, not on my end.
I can hear you.
Oh.
What are your thoughts?
So I actually was very similar to what you guys were saying. I figured, we could come into the session with the disclaimer of, I am a counselor, I am not your psychiatrist or your PCP, so I can give you this general information and be able to go over like what this book says. And I'd also offer, like, in our sessions, I'd like to take at least a couple of minutes for us to be able to follow up on how the medication is going and if there are side effects that you're experiencing. But if it comes to you're really experiencing difficult side effects, hi Little, then then that is where you'd want to be able to go back and talk to your psychiatrist, your PCP, whoever just prescribed that medication. And that would also be a really good place, again, to be able to talk with them about that partnership that you would like to have with that prescribing professional, so that you are on the same page and he knows that you're in a collaborative unit to continue to help him. So it could be a really good place to even have that discussion.
Like an integrative care, is that what you're saying?
Mm-hmm. Whether that's all in one site, or if you're just using the ROI to be able to talk with the psychiatrist or doctor, whatever that is, just to continue to let the client know, like, this is an ongoing process. And I want to be in that advocating role of being able to help you find what works best for you.
And I guess have that collaborative relationship with their psychiatrist.
Mm-hmm.
You know, say, okay, now if you're having these problems, if you give me consent to talk with
exactly
your whoever prescribed the medicine,
right?
You know, and you know, if you have any concerns, you know, we can all sit down together and talk about the concerns. But I cannot talk about your side effects. But here, like Elisa said, the general information about the side effects. You know,
Mm-hmm.
That was a way easier way to say it than what I said.
Well, you went first, so I mean, it was harder for you to blaze the trail. Cool. How do we feel about that one? Good?
yes.
Number 3. Hopefully, Rachel, we get her back.
Oh, go ahead. You go first.
So, yeah, just why do you think the doctor was hesitant to prescribe the alprazolam?
Okay, my first thing, because alprazolam is Xanax, right, is because he's nervous driving. So he's going to want to take it when he's driving,
Mm-hmm.
which Xanax can make you very, very sleepy, and your reflexes are not, it's like being stoned,
Mm-hmm.
you know. Not forever, but while you're getting used to it, especially, you know.
Okay.
It's very highly addictive. I don't know if he has previous addiction issues. I mean, I don't know. I think now they try to kind of stay away from that because it's a controlled substance now.
Mm-hmm.
But he may have had issues with things in the past that we don't know about, too. I mean, that's why I'm wondering what the therapy was for before. You know what I mean?
Mm-hmm.
Well, I guess the questions to me probably was a little backwards, because if you look at the next question that Gary asked, if he would be strung out, you know, he asked about being addictive. So I just felt like it was out of order. Because the next one, it was like Gary asked if he would get strung out on that medicine, and how do you respond to that? Whereas then it's like, why do you think the doctor was hesitant to prescribe
Alprazolam.
Okay. But you see what I mean? So is his hesitation because he would become dependent, or because that's the question Gary was asking? Would he become dependent on that particular drug?
Sorry about
Well, and I was thinking, even with that, so the reason he didn't like the other medication that he was prescribed beforehand, one of the reasons he said it made him feel sedated.
Yes.
And this also is going to make him feel sedated. So if he's needing to take that, not only driving to work, but then needing to be at work and be able to function at work, that might be one of his biggest concerns.
Right.
Sorry, guys. I don't know what happened to my video.
I don't know, but we got you back.
Do you see us?
Also,
I
I'm
see
gonna
that.
let you guys know that we have like 7 minutes left.
Okay, don't worry about my ranting of going off. Well, I will question 4.
Finishing up 3. What do you think?
Oh, okay.
We're finishing up 3. Wait a minute, which one was 3? That was a
See,
side
Why
effect.
do you think the
So
doctor was
why do you think the doctor was hesitant to prescribe you know what, I just looking through the side effect, they all have the same side effect, but then for some reason he says the what's that called, the alprazolam works for him, that he likes that. That's the same one that a friend was concerned about, that he would get addicted to. So it's the same side effect. So I don't know, because if that was there was one, the which other one was making him sedated. So this is gonna do the same thing. So but then he likes this one better. So I really don't have an answer, but I don't know. It's kind of, they all have mostly the same side effects. So I don't know how that's gonna help him, or why this one works better for him. Yeah.
Mm-hmm.
No, I think the one that made him, maybe I misstated, was the buspirion that made him sedated.
Yeah.
The buspirone made him feel sedated, and buspirone and alprazolam are two totally different classes of medications.
Mm-hmm.
Okay.
And I think if he knows that sedation is a possible side effect of this as well, that might be why he is, again, hesitant or concerned in thinking, this is just going to have the same side effects.
Mm-hmm.
Okay, yeah.
So again, as you just said, Jennifer, I mean, that could be part of the psychoeducation, is being able to tell him this is a completely different class of medication. And again, even saying, hey, have a conversation with your psychiatrist, that they would be able to explain that more. And even having a conversation with the psychiatrist about that and his concerns, and advocating for him so that the psychiatrist knows how to provide, I guess, psychoeducation in his realm, his or her realm, in an inquisitive, one-down way.
You know what? I just actually saw something else in this case study, is that this Gary actually drinks. He's a moderate user of alcohol, 4 to 6 drinks per week. Mm-hmm. And when I look at this medication, it talks about seizures on abrupt discontinuation. Then it's interactive with alcohol, antidepressants. So there's a caution that not to drink with this. So that could also be a reason why he was hesitant to give him this particular medicine, because would he stop drinking, or would he take this medicine even when he's drinking 4 to 6 drinks per week? Because this is up under the caution, the assessment cautions.
That's how overdoses usually happen, is with the alprazolam, is usually with alcohol or another substance, because it,
so what happened?
Slows your heart rate.
So maybe that was another reason why he was hesitant about giving him this medication, since in the beginning of this case it says he does drink 4 to 6 drinks a week. So that could be a hesitant.
Well, and I was reading that as well and thinking the same thing, and then I read mostly on the weekends. So I was like, well, he could have, but the doctor prescribed it, so it's a daily thing.
Right, it's a daily, yeah.
Well, and if he has PTSD and he hits a point where he's like really rock bottom,
yeah,
that may not stop him from misusing the medication to cope, and then end up in a very lethal situation.
Right. Yeah. So as the counselor, what would our role be then in having that conversation?
Quick pause. Are we going to have to do another one of these?
We have 3 minutes, so we might be able to get through it, is my hope.
We're not even on 4 yet, right?
But we're almost on 4.
Well, we talked about Gary stated to be, okay. So the 4th question, I don't know, maybe I did something different. Why did the doctor hesitant to prescribe that? What number do you have that? I have that
3.
as, you have that as 3, and then number 4 is, okay. And Gary asked you if he would get strung out. How do you respond? That's the last question, right?
Mm-hmm.
Mm-hmm.
I would just, I mean, you're not going to with that, but I wouldn't just say that, obviously. Maybe something like that's not a typical side effect of it. Valium and Xanax, even though they're in the same class, are different concentrations and different purposes.
See, you know that. I wouldn't know that.
Mm-hmm.
So I wouldn't say all that.
Right. But
Yeah.
that's, I mean, they're both benzodiazepines, but Xanax is more concentrated. Valium is longer acting and more of a muscle relaxant. As to where Xanax, the alprazolam, is made for anxiety, specifically for panic attacks.
Okay, so up under the caution, it talks about physical dependence. Is that something different?
No, I mean, you can become physically dependent on both of those.
Okay.
It's actually more likely in alprazolam. It's more sedating because it's more concentrated. But if people are going to use substances, I mean, they're going to regardless.
Okay.
Okay.
We have, okay.
But yeah, I mean, he's not going to get strung out. But I wouldn't say that.
So we would basically tell him that the doctor, he will work closely with his doctor, prescribing doctor, who will monitor it closely to you know,
yeah,
because they know better about the addictive.
I guess as a therapist, I would be wanting to know, why are you worried about this? Why you feel like you're worried about being
Because his friend told him.
Well, right, but he's so worried about being
Addicted.
sleepy and everything, but he's worried about being strung out. So
Yeah.
what, and why are you worried about becoming addicted to it?
That's a cultural thing, Jennifer. In the African American culture.
What is, well, explain it to me if you can.
Alcohol, drug abuse, that's like something that you see a lot in the African American community. And that's one thing that African American tries to stay away from, is addictive type medication.
Medication, yes.
Right. So I mean, we still have to look at the cultural side of this.